السلام عليكم.
عليكم السلام.
Good afternoon, everyone. Welcome to our academic activity for today. So today we have three presentations. The first one is about pathophysiology and diagnosis of aortic aneurysm. Will be presented by Dr. Ghad Al-Harbi. And second lecture about ascending aortic aneurysm by Dr. Ahmed Al-Ghamdi, and we will end up by journal club about EVEREST trial by Dr. Muhammad Al-Mutlaq. So we shall start in 5 minutes, inshallah. Dr. Ghada. Ghada, we can't hear you.
دكتور غادة الصوت ما في صوت عندك. تقدرين توقفين الشير سكرين وراح تحصلين الجوين اوديو. بعدين ارجع للشير سكرين عقب.
She cannot hear us, عبد الملك. Trying to call her now.
تمام، هي لازم بس انها تسوي جوين اوديو عشان حتى تسمع وتتكلم.
Okay, Khalid's trying to reconnect again. So Ghada is still having an issue with her connection, so we'll start with the journal club, and after that we'll resume the lectures again with Ghada. Mohammed, you can prepare your presentation. Thank you.
اوكي. على كل شيء قدامكم. السلام عليكم.
عليكم السلام ورحمة الله. واضح كلش.
واضح؟
ايه.
زين بسم الله. السلام عليكم. My name is Dr. Mohammed Al-Mutlaq from King Khalid University Hospital, cardiac surgery resident. Today, inshallah, I will present the EVEREST trial that compare between the percutaneous mitral valve repair with the surgery for mitral regurgitation. So there is two studies, different duration, but same patient. The first one published in 2011 in New England Journal of Medicine. The other one published in 2015 in the Journal of American College of Cardiology. So same patient, but different duration. So the conclusion for this study was any patient candidate for the mitral valve surgery, any patient moderate to severe grade 3 or 4 mitral regurgitation, symptomatic patient if ejection fraction more than 25, left ventricle end systolic diameter less than or equal 55, a symptomatic patient with ejection fraction between 25 and 60 or left ventricle end systolic diameter more than 40 or pulmonary hypertension or arterial fibrillation. The other inclusion was no need for other cardiac surgery, no endocarditis, no rheumatic heart disease, mitral valve anatomical that fit for percutaneous repair, mean cohabitation length more than 2 millimeter, cohabitation depth less than 11, flyal gap less than 10, flyal width less than 15. So the aim of the study to evaluate the final 5-year clinical outcome and durability of the percutaneous mitral valve repair with the mitral clips compared with the conventional mitral valve surgery. So the first data we have it for the major adverse event at 13 days showed the superior safety for percutaneous repair group compared with the surgery. So the safety come with more safety with the percutaneous repair. So the other table at 12 months, we saw here at 12 months, the rate of reoperation for mitral valve dysfunction was 20 in the percutaneous repair group, and comparing 2.2 for repeating mitral valve surgery in the surgical group. Overall, the rate of the primary efficacy endpoint composed of the freedom from death and from surgery for the valve dysfunction and from the grade 3 or 4 mitral regurgitation at 24 months here, 51 for the percutaneous repair and 66.3% in the surgical group. The other study was published in 2015 for the 5 years. The rate of composite endpoint freedom from death and surgery or grade 3 or 4 mitral regurgitation was 44.2 versus 64 in the percutaneous repair and surgical group, respectively. The difference was driven by the increased rate of the 3 or grade 4, 12.3% versus 1.8 and the reoperation here 27% and 80.9% with the percutaneous repair. There was no difference in the death between these two groups. Here, the Kaplan-Meier curve for 5 years show the freedom from the death and surgery for mitral valve dysfunction was 60% with the percutaneous repair versus 73.3 for surgical group. And there is no difference between two curves for the surgical group and the percutaneous group. The other difference is the freedom from the mitral valve surgery or reoperation was 79.6% for percutaneous repair and 91.3 in the surgical group. And if we exclude the first 6 months, the curve will be same. That means the most of surgery occur within the first 6 months. Beyond the 6 months, there was no difference in the rate of freedom from reoperation for mitral valve dysfunction. The other comparative study for clinical outcome measures at 5 years, including mitral regurgitation, New York Heart Association functional classes, and left ventricular volume. So other compare was, we see here, after 5 years, the reduce in the mitral regurgitation more than percutaneous repair for the surgery. I mean, around 81 for percutaneous repair. Here, 81 was reduction in the percutaneous repair, and 97 in the surgical group. In the hospital the hospital mitral regurgitation reduction. So for the classes for New York Heart Association classic function, we see here, despite the increase in the mitral regurgitation reduction with the surgery, the functional classic 3 and 4 symptoms were more frequent experience at 12 months with the surgery compared with the percutaneous repair, 8% versus 1. And at 5 years, no significant reversal of this trend was, we see here, that from 1 to 9 and from 8 to 3 in the surgical group. The trend was observed such that 9% of percutaneous repair patient and 3 of surgical patient was classed as have New York Heart Association functional classing 3 or 4 symptom. And we see here the numbers. Left ventricle in diastolic volume continue to improve for two group between 1 and 5. Almost same, but better with the surgery. A small increase in the left ventricle internal diastolic diameter was observed late after both percutaneous repair and surgery. Left ventricle internal diastolic diameter was significantly smaller at 1 and 5 years with the surgery compared with the percutaneous repair. And here the other comparing subgroup between male and female, sex, and age more than 70, less than 70, functional mitral regurgitation, degenerative, left ventricle ejection fraction, less than 60 and more than 60. We saw here surgery performed better than percutaneous repair in the younger patient. Surgery was superior to percutaneous repair in the patient with the degenerative mitral regurg. Left ventricle ejection fraction was observed with the superior result seen with the surgery in those with the left ventricle ejection fraction more than 60. In the summary, percutaneous repair procedure demonstrate increased safety compared to the surgery. Surgery reduced mitral regurgitation more than percutaneous repair, around 81 for percutaneous repair and 97 for the surgery. Had in the hospital mitral regurgitation reduction to grade 2 or less. However, improvement in the left ventricle remodeling and the clinical outcome were similar for both approach. Both groups showed improvement in the left ventricle function for the functional classic and the quality of the life. There was no significant difference in the mortality between surgery and percutaneous repair at 5 years. Patients treated with the percutaneous repair most commonly require surgery for residual mitral regurgitation during the first year after treatment. But between the first year and 5 year follow-up comparably, low rate of the surgery for mitral valve dysfunction with the either percutaneous or surgical therapy endorse the durability of the mitral regurgitation reduction with both the repair technique. This is the two published study. This is the first one in the 2011, the other one in 2015. Thank you.
Can we ask questions or what's going on now?
Yes, Dr. Farid. Okay.
Yes, Dr. Farid.
So my first question, the mortality rate you have wrote is something like 20%.
0.8.
Isn't that a little bit too much for?
And
Oh,
20, some more, yeah, the data showed some patient died without known cause. Yeah. So they put it
So
as
so normally when we look at mitral valve replacement, let's say, we would think that it has a mortality rate maybe somewhere in the range of 4 to 5%, all comers. So why is this group having so much higher mortality rate?
this is
From
for
your
5
review, I know
for,
for
yeah, for 5 years the data, and some patient die not related to the mitral valve function. So the other cause.
so
But
let's
they
say
put the data.
let's say if I have somebody who's age 20 years old and I replace the mitral valve, 5 years is very short term basically, and I don't expect mortality in this patient. Just like I said, maybe depend on the LV, maybe depend on the disease status. I would say maybe somewhere in my hand 2-3% maybe. Older patient may go up to 5-8%, maybe 10% even if it's including cabbage. So those are the general numbers, but why this particular group have high mortality from your review and from your study of this article?
From my review and from the study, the article showed some patient here we saw here. Some patient died with no cause or with no reason to the this study. There is no relation between the mitral valve function for this patient and for the death. So I know that the number is very high, but the article say like this.
What was the center that it was done in?
Which one?
The study. This study was done in heart. So when and where, that can make a difference sometimes. The surgeon's experience also can make a difference. If you tell me this very huge center, one center, or if it's multiple centers that they do maybe 3-4 cases a year, that's the,
yeah, it's multiple centers.
Where? Where are these centers?
It's done in between 2007 and 2008, mainly in the, I think in the England. The head was Ted Feldman. He's the vascular, and shared with these people. That's what I know about this study.
Okay. And you reviewed this article, so you should go dig into all these details, and it should start to have such a mortality. But again, 5-year difference, regardless of the high numbers, 5-year difference between the surgical and the clip, with 80% success rate in a mitral clip, this will sway me to mitral clip, knowing the fact that 20% will require another step, or maybe surgery or something like this. What's your inferences? How do you interpret this article? What is your take? How is that going to change your practice?
From my side, really, I don't know for this. I didn't consider.
So those are the questions you ask yourself in a journal club, and everyone should really know some of these. Okay, from the first time, you're probably not aware of all these, but put those questions as you go through the article. It helps you to define. Sometimes it could be a biased article, biased by the patient selection, by the funder, whoever's giving you the funds to do the procedure or the research. It could be the company that have used the clip, for example, and they're trying to promote it. So there are many other factors that you need to look between the lines and read. Who are the surgeons involved? Who are the cardiologists involved? How the decision is made? Was there any difference in the groups? Quite a few of the points that you have mentioned did not show any difference between the two groups. I mean, in the selection. But again, we should look into more details. If you tell me age is 70 and more than 70, less than 70, you may find sicker patients less than 70, and you may have healthier patients above 70. The same for the ejection fraction. 60% is almost normal. But of course, with severe regurgitation, it's maybe overestimated. So you need to look at other parameters, looking at why this patient is symptomatic. And probably these things are mentioned somewhere in the article. Okay, thank you. That's my take.
Thank you.
Thank you, Mohammed.
يعطيك العافية. يعطيك العافية دكتور فريد، يعطيكم العافية جميعا، شكرا لكم.
So just a piece of advice for the future presenters for the journal club: try to find one of the critical appraisal forms for the journal club, and you may go back to Haytham al-Bar lecture on when we started the activity on how to present a journal club, just to get the most benefit out of this. So I'll try to call Dr. Ghadaf, see if she's ready, and we'll come back to you. So we'll have a 5-minute break, and then we'll start with Dr. Ghadaf.
ألو
الو السلام عليكم.
السلام عليكم. Did you hear me?
يس
معلش على التأخير اللي صار. How are you everybody? I am Ghada Al-Harbi from Medina Cardiac Center. My lecture today is about aortic aneurysm. Outlines of aortic aneurysm regarding surgical anatomy, definition, pathogenesis, clinical presentation, natural history, and diagnosis. Quick review regarding the aortic root anatomy. Aortic root resemble a box which has roof, wall, floor, and content. Roof formed by sinutubular junction that extend from the distal part of the sinuses and the proximal part of ascending aorta. And 15 to 20% is smaller than the annular diameter in young patients and become larger with age. Wall formed by sinuses of Valsalva, which extend from the sinutubular junction until the aortic annulus. Floor of the root formed by the aortic sinuses and the content, aortic valve, valve leaflet attachment, and subcommissural triangle. About ventricular arterial junction lies between myocardium and aortic sinus, the basal ring that joins the inferior aspect of the valve leaflet. Definition of the aneurysm. Aneurysm is defined as permanent dilatation of an artery at least 1.5 times its normal diameter at given location. The normal aortic diameter is more difficult to define and also varies with person age and body surface. At the level of the ascending aorta, it's 25 to 35 millimeter, and aortic arch from 25 to 30 ml. We start with ascending aorta. Regarding pathophysiology, histologically, the ascending aorta contain a high proportion of elastic tissue, allowing it to serve as reservoir and that store kinetic energy from systolic pulse wave as it expand and use it to maintain flow during diastole via elastic recall. The ascending aorta is a three-layer structure composed of small intimal layer, which is single layer of the endothelial cells adherent to basal lamina, medial layer composed of layer of elastin sheath, collagen, smooth muscle cell, and extracellular matrix, outer layer of adventitial tissue, which includes the vasovasorum and nerves. The elastin content of the aorta decreased distally, so in the abdominal aorta is less than half of that in ascending aorta. Ascending aortic aneurysm formation is a result of several biological and mechanical mechanisms. Disruption of the balance between hemostatic mechanism within the aortic wall, including elastic and collagen elements, protoglycans, proteolytic enzymes and their inhibitor, and inflammatory mediator, causes a spectrum of aortic pathology that manifests in the final pathway as aortic enlargement, leading to rupture or dissection. The principal biological cause of aneurysm formation in ascending aorta are related to degenerative process in elastic media as compared with the primary atherosclerotic changes in descending and abdominal aorta. Fragmentation of extracellular matrix of aortic media occurs because of matrix degrading enzymes such as matrix metalloproteinase. Aneurysm form as elastic layer fragment. Smooth muscle cells become dysfunction and eventually elastic, and smooth muscles component are replaced with the cystic appearing mucoid material. This process is related to cystic medial degeneration. This is the histological picture of systolic medial degeneration in the middle. A mild degeneration of the aortic wall is common with advanced age, and it's responsible for slow dilation of the ascending aorta with the age. Smoking tends to exacerbate this degeneration. Mechanical changes the aortic wall characteristics such as alternation in cross-sectional symmetry, compliance, and stress-strain relationship. The Laplace relation describes the association between aortic diameter and wall tension, in which increase in aortic wall diameter lead to increase in wall stress at similar pressure. Change in aortic wall compliance, broadly defined as change in volume of the vessels with a change in the pressure, lead to increased stress applied to aortic wall during the systolic impulse and further exacerbate the biological degeneration leading to aneurysm formation. Degenerative aortic aneurysm cause asymmetric enlargement of the ascending aorta because the segment of aorta along the inner curvature is adherent to the pulmonary artery. Hence, there is significant rightward and anterior displacement of the aortic wall. This causes a relative enlargement of ascending aorta in asymmetrical fashion, tend to push the heart into horizontal arrangement. This also causes a significant change in orientation of aortic valve annulus to more oblique arrangement. Aneurysmal widening will typically involve the aorta to the level of the sinotubular junction and frequently involve the non-coronary sinus to lesser extent. This widening at the level of the sinotubular junction is responsible for aortic insufficiency in these cases, and the frequent placement of the tube graft to the sinotubular junction will result significant central aortic insufficiency. The left and non-coronary sinuses are fairly normal in these cases. A specific etiology, Marfan syndrome, is the autosomal dominant syndrome. Overall incidence is 1 per 3,000 to 10,000 live births. Traditionally, it's thought to have been caused by alternation in gene fibrillin, coding the aortic wall protein fibrillin-1, leading to elastin degeneration, medial degeneration, and aneurysmal formation. More recently, homology between fibrillin-1 molecules and latent transforming growth factor beta binding protein lead investigator to infer that altered sequestration of the latent form of the transforming growth factor beta in extracellular matrix may increase growth factor beta activity, which negatively affects smooth muscle development and extracellular matrix. 80% of patients with Marfan syndrome develop aortic root aneurysm, and nearly half develop mitral regurgitation. Anatomically, Marfan syndrome results in severe aortoannular ectasia and massively dilated sinus and aortic annulus. More recently, reports have shown that the use of the AC inhibitor can prolong the life expectancy of the smooth muscle cell in aortic tissue of Marfan patient via angiotensin 2 type 2 receptor block mechanism, which antagonize the transforming growth factor beta. This lead the clinical application of the angiotensin receptor blocker losartan as a prophylactic therapy to diminish aortic degeneration and aneurysm formation, which has been shown in animal models to be effective when given in early stages of disease. Patients with Marfan syndrome are particularly high risk of rupture or dissection of smaller sizes, and dissection is frequently seen with the maximum ascending aortic dimension of less than 5 to 6 centimeters. Marfan syndrome, Marfan's patient with a family history of early dissection or rupture are at highest risk for aortic catastrophe occurring at smaller diameter. The average age of death for untreated patients with Marfan syndrome is 32 years, with complication of aortic growth being responsible for 60 to 80% of these deaths. This is the picture of massively dilated aortic growth in Marfan syndrome. Loeys-Deitz syndrome is more recently described autosomal dominant syndrome resulting from mutation in transforming growth factor beta receptor 1 and 2. Characteristics of this syndrome include left palate, bifid uvula, sclerosis, orbital hypertelorism, pectus deformities, developmental abnormalities, and congenital heart defect, including persistent patent ductus arteriosus and arterial septal defect. Histologically, it's associated with increased medial collagen, diffuse form of elastic fiber fragmentation, and extracellular matrix deposition. It has a more rapid clinical course than Marfan syndrome, and prophylactic aortic root replacement or reimplantation is often recommended at younger age with a smaller aortic dimension. Ehlers-Danlos syndrome, caused by either sporadic mutation or inheritance autosomal dominant trait, resulting in connective tissue disorder from the defect in type 3 collagen. The type 4 variant of the Ehlers-Danlos syndrome, associated with spontaneous arterial rupture, most commonly in mesenteric or carotid arteries. However, spontaneous rupture of descending aorta and aortic arch has been described. The arterial wall of this patient is extremely thin and friable. Ascending aortic involvement may occur as a consequence of retrograde extension of the primary brachiocephalic branch pathology. Infectious and inflammatory etiology. Ascending aortic aneurysm caused by infection are extremely uncommon. Such mycotic ascending aortic aneurysm are frequently related to concomitant left side valvular endocarditis, most common organism, Staphylococcus aureus and Epidermidis, Salmonella and Streptococcus. In case of atherosclerotic aneurysm, if there is intraluminal clots in the ascending aorta, transient bacteremia may lead to infected clot leading to a mycotic aneurysm. Syphilis caused by Troponemia pallidum was the predominant cause of ascending aortic aneurysm in the pre-antibiotic era and account for 5 to 10% of all cardiovascular death. Typically, syphilis aortitis involved the thoracic aorta with particularly predilection for the ascending aorta, likely ongoing its rich vascular and lymphatic supply. The pathological process involved multifocal lymphoplasmacytic infiltration of the vasophozorum, leading to degeneration of the medial elastic fiber. The intimal develops wrinkles, ridge, called tree bark appearance. Inflammation around the coronary artery ostia may lead to high-grade proximal occlusion. The inflammatory process may be patches or diffuse, involve a large section of aorta. Once established, the treatment of the syphilis with antibiotics doesn't prefers the vascular lesions. This is a CT scan picture showed ascending aortic aneurysm with extensive calcified plaques. Other systemic arthritis condition may also produce ascending aortic aneurysm. Takayasu arthritis associated with inflammation of the vasophozorum and medial necrosis, and maybe also have intimal changes similar to the syphilis, typically seen in women between 15 to 30 years of age and frequently involve lesion to major branch vessels of the arch. Giant cell arthritis is systemic arthritis with inflammatory process, include infiltration of lymphocyte, plasma cells, and histiocyte. There is variable presence of giant cell. It occurs in elderly patients, most commonly affecting the temporal artery. Aortitis leading to aortic aneurysm may also associated rarely with Paget disease, rheumatoid arthritis, sarcoidosis, ankylosing spondylitis, lupus erythematosus, and Wigner granulomatosis. Other causes like bicuspid aortopathy. Bicuspid aortic valve is a complex familial syndrome with the male predominance of 3:1. 9% prevalence of bicuspid aortic valve disease in first-degree relative of patients with a bicuspid aortic valve disease. More than half of patients with aortic coarctation have an associated bicuspid aortic valve. Aortic dilation is frequently associated with bicuspid aortic valve. However, the mechanism for this is not well established. Recent investigation has shown that embryologically, the aortic valve and ascending aorta arise from the neural crest cell, implicating a potential common mechanism for the development of bicuspid aortic valve and subsequent aneurysm formation. The aortic wall in bicuspid aortic valve show increased elastic fragmentation, fibrillin-1 deficiency, matrix disruption, increased level of matrix metallic protease, and smooth muscle cells apoptosis. Isolated sinus of Valsalva aneurysm. Aneurysm of the sinus of Valsalva that occur as isolated lesion are rare abnormalities caused by either congenital defect in the continuity between medial layer of the affecting sinus and the aortic valve annulus, or less commonly acquired causes such as endocarditis, syphilis, TB, focal dissection, or iatrogenic causes. They are more common in male and may associated with subaortic stenosis, ventricular septal defect, and aortic insufficiency. In greater than 90% of cases, they involve the right coronary sinus. The non-coronary sinus of the second most common location, and these aneurysms are extremely uncommon in left coronary sinus. They are generally asymptomatic until they rupture, when they usually cause intracardiac shunt. Right sinus of Valsalva aneurysm rupture into the right ventricle, causing hemodynamically defect similar to ventricular septal defect. Non-coronary sinuses aneurysm rupture into right atrium. The left coronary sinus rupture into pulmonary artery or left ventricle. Clinical presentation. Most ascending aortic aneurysm are asymptomatic when diagnosed, being incidentally noted on chest X-ray or echo. Anterior chest pain is the most frequent symptoms. The pain may be acute in onset, signifying impending rupture, or chronic pain from compression of the sternum. Signs of superior vena cava or airway compression may present. Hoarseness resulting from stretch injury of the left recurrent laryngeal nerve suggests involvement of the distal aortic arch or proximal descending thoracic aorta. Less commonly, aneurysm of the ascending aorta or aortic arch can rupture into the right atrium or superior vena cava, presenting with high output cardiac failure, or bleed into lungs with hemoptysis. Acute dissection of the ascending aorta present with a severe tearing pain in greater than 75% of patients. Physical examination is often unremarkable. If there is related aortic insufficiency, wind pulse pressure or diastolic murmur may be present. If dilation is isolated to ascending aorta, however, the aneurysm can reach large dimension without producing physical findings. Vascular examination should be carried out to look for any concomitant peripheral vascular disease, carotid disease, or abdominal aortic aneurysm. Abdominal aortic aneurysm may be present in 10 to 20% of patients with atherosclerotic involvement of the ascending aortic aneurysm. Regarding diagnostic studies, chest X-ray, many asymptomatic ascending aortic aneurysm are first detected on chest X-ray. The enlarged ascending aorta produces convex contour of the right superior mediastinum. In the lateral view, there is loss of the retrosternal airspace. This is a BA chest X-ray with convexity of the mediastinum. representing the ascending aortic aneurysm. The second picture of the lateral chest X-ray with loss of normal retrosternal airspace. ECG with significant aortic insufficiency, left ventricular hypertrophy is evident. Patient with generalized atherosclerotic may show evidence of concomitant coronary artery disease or previous myocardial injury. Echo TEE is a portable diagnostic tool that detects and differentiates among ascending aortic aneurysm, dissections, and intramural hematoma. Imaging of the distal ascending aorta is obscure because of air in the tracheobrachial tree. The TE carry a small risk of esophageal perforation, respiratory compromise, and hemodynamically instability. Transthoracic echo is far less reliable, but may be useful for assessing of the severity of aortic regurgitation. Contrast enhanced CT is the most widely used non-invasive technique for imaging the thoracic aorta. It provides rapid, precise evaluation of the ascending aorta regarding size, extent, location of the disease, and detect area of calcification. Non-contrast CT allow assessment for an aortic diameter but cannot identify dissection flaps or other acute pathologies. First picture, CT angiogram of enlarged aortic rod in Marfan syndrome patient. And second picture, a three-dimensional reconstruction of enlarged aortic rod also in patient with Marfan syndrome. MRI can provide axial and three-dimensional reconstruction of ascending aorta with the avoidance of contrast agent and radiation exposure. Contrast enhanced MR angiography with gadolinium allow more precise measurement of aorta and its major branch with image relative to the conventional angiography. It's relatively unsuitable for patients connected to mechanical ventilation or hemodynamically monitoring equipment. Bickerstaff about the natural history of ascending aortic aneurysm. Bickerstaff and colleague examined the natural history of 72 patients who were diagnosed with aortic aneurysm and did not undergo surgery. Over 5 years follow-up period, 74% of patients experienced aortic rupture or dissection. 94% are died. The overall 5-year survival was only 13% in untreated aneurysm patients, compared with 75% in control patients without aortic aneurysm. In natural history study by Cody and colleagues, patients with 3.5 to 3.9 centimeter aortic aneurysm very unlikely to rupture within 3 to 4 years, and each incremental 1 centimeter increase from this point increased rupture risk. Patients with aneurysm greater than 5 centimeters show higher dissection and rupture risk within the first year. Using a logistic regression model, they found that the aneurysm with maximum diameter 6 to 6.9 centimeters had a 4.3 times greater increased risk of rupture or dissection than the aneurysm that is 4 to 4.9 centimeters in diameter. Growth rates for aortic aneurysm less than 4 centimeters is about 0.1 centimeter per year and increase gradually as aortic size increase up to 0.4 centimeter per year. Uncontrolled hypertension, smoking, and persistence of connective tissue disorder are associated with more rapid aortic growth. A second part of the lecture regarding descending and thoracoabdominal aortic aneurysm. The distal aortic segment comprise the descending thoracic aorta, which extended from the left subclavian artery to the diaphragm within the chest and the abdominal segment that extend from the diaphragm to the iliac bifurcation. An aortic aneurysm that is limited to chest is classified as descending thoracic aortic aneurysm, and aortic aneurysm that transfer the diaphragm and extend into both chest and abdomen to any degree is considered as thoracoabdominal aortic aneurysm. Regarding the measurement and diameter, at the level of mid-descending thoracic aorta, the average diameter is 28 for men and 26 mm for women. And at the level of the celiac axis, it's 23 mm for men and 20 mm for women. At the infrarenal aorta, it's 19.5 millimeter for men and 15.5 for women. Pathogenesis. The etiology of descending thoracic aneurysm and thoracoabdominal aneurysm has changed over time. Syphilis was the most common cause of thoracic aneurysm before. Other causes are more prevalent today. Well-established cause of descending thoracic and thoracoabdominal aneurysm include medial degeneration, atherosclerosis, aortic dissection, connective tissue disorder, aortitis, aortic coarctation, infection, and trauma. Thoracic aortic aneurysm are primarily the result of age-related medial degeneration, which characterized by change in elastin and collagen that reduce aortic integrity and stretch. Subsequent aortic enlargement and aneurysm formation provide fertile ground for superimposed intimal atherosclerosis and further degeneration of the aortic wall. As with most aneurysmogenic process, medial degeneration usually causes diffuse fusiform aortic dilation. In some cases, however, medial degeneration produces a saccular aneurysm along the descending thoracic aorta. This saccular aneurysm may be superimposed on or coexisting with more generalized fusiform aneurysmal disease of thoracoabdominal aorta. Risk factors for aortic dissection and aortic aneurysm overlap to a great extent, but once an aortic becomes dissected, the dissection itself becomes independent risk factor for subsequent dilatation and aneurysmal changes. Aortic dissection occurs in the medial layer, separating the intimal from the adventitia. Blood flow through the true aortic lumen and through one or more false lumen channels that can form various points along the aorta. This process weakens the outer aortic wall, making it prone to aneurysmal formation. Persistent or pressurized false lumen has been associated with subsequent aneurysmal formation, need to intervention, and increased mortality. Recent endovascular strategies have included stent exclusion of the false lumen in attempt to thrombose the false lumen, thus decrease the risk of late aneurysm formation, although this technique remains controversial. Genetic mutation or defect can give rise of a defect component of the aortic extracellular matrix, leading to aortic aneurysm and dissection. Marfan syndrome is most common genetic cause of thoracic aneurysm in 36%. Ehlers-Danlos syndrome causes 5% of genetically thoracic aneurysm. Both chronic non-specific aortitis and systemic autoimmune disorders such as Takayasu arthritis, joint cells arthritis, rheumatoid aortitis can cause this destruction of the aortic media and progressive aneurysmal formation. Aneurysm importing the upper descending thoracic aorta can develop in patients with the congenital aortic coarctation. These aneurysms occur concomitantly with unrepaired coarctation or after coarctation repair. The post-repair aneurysm appear to be most common in patients who had patch graft aortoplasty operation. Pseudoaneurysm of thoracic aorta form as a result of the chronic leak through discrete defect in the aortic wall. This leak are initially contained by the surrounding tissue. The the accumulation of the organized thrombus and associated fibrosis form the wall of the pseudoaneurysm. It can develop after surgical or percutaneous repair of aortic cortication, dissection, or aneurysm. Unrepaired blunt and penetrating injury are the other common cause of pseudoaneurysm. Chronic traumatic pseudoaneurysm typically develop in proximal descending thoracic aorta after blunt aortic injuries. Regarding the natural history, the descending thoracic aorta has slightly higher rate of expansion over time than the ascending aorta and is noted to average 1 to 4 millimeter per year. The rate is not constant and it's increased as the diameter increases. A tear can occur within the intimal and medial layer, resulting in dissection that propagate down the length of aorta, or a tear can penetrate the full thickness of the aortic wall, resulting in contained or free rupture. In thoracic aorta, there is a sharp increase in incidence of aortic complication of aneurysmal diameter greater than 6 centimeters, with a 14% combined risk of rupture, dissection, and death. In population-based study, the 5-year risk of rupture doubled from 16% for aneurysm size from 4 to 5.9 centimeter in diameter to 31% in aneurysm 6 centimeter or more in diameter. Clinical presentation: at the time of the diagnosis, patient with the descending thoracic aneurysm or thoraco-abdominal aneurysm are commonly asymptomatic and often discovered when image study are performed for unrelated problem. Degenerative thoraco-abdominal aneurysm produce symptoms in approximately 57% of patients. 9% of patients present with rupture. The most frequent symptoms is back pain between the scapula. When the aneurysm is large in the region of the aortic hiatus, pressure on adjacent structure may cause mid-back and epigastric pain. Other potential signs and symptoms related to compression or erosion of adjacent organs include stridor, wheezing, cough, hemoptysis, dysphagia, and gastrointestinal obstruction or bleeding. Hoarseness results from traction on vagus nerve as the distal aortic arch expands and causes recurrent laryngeal nerve paralysis. Thoracic or lumbar vertebral body erosion cause back pain, spinal instability, and neurologic defects. From spinal cord compression, mycotic aneurysm have a property to destroy the vertebral bodies. Neurological symptoms include paraplegia, paraparesis, or both, may result from thrombus of intercostal or lumbar arteries. This is most frequently seen in acute aortic dissection, which may occur primary or superimposed on medial degeneration fusiform aneurysmal disease. This is a picture of thoraco-abdominal aneurysm with the calcification. This is the CT scan. This is a CT scan shows advanced aneurysm. This is a coronal, sagittal, and axial fuse. The last picture, the large abdominal aortic aneurysm, which showed calcification and the thrombus inside the lumen. Any question?
Thank you, Ghader. Any question or comment for Ghader? Okay, we'll have another 10 minutes break and we'll start the last lecture.
اوكي دكتور لؤي، السلام عليكم.
السلام ورحمة الله.
يعطيكم العافيه جميعا. Can I start or
خلصت ال10 دقائق؟
10 دقائق ولا دقيقتين؟
10 دقائق.
سمعت اوكي. Sorry.
أحمد.
أيوة سم.
تفضل.
طيب بسم الله. السلام عليكم. Good afternoon, everybody. I'd like to thank Dr. Agada for her presentation and overview about the ascending aortic aneurysm and the pathophysiology as well as the clinical presentation. So I'm going to talk about the surgical indications and the management of this pathology. But let me first introduce myself. I'm Ahmed Al-Ghamdi, cardiac surgery resident at King Abdullah Medical City. So a lethal disease, and the question should be raised after identify the patient with this pathology is at which size does the aortic okay. So several studies revealed that the aortic size, which is reached 6 centimeter, is more prone to complicate with the dissection or rupture. And this defines the hinge point for which we have to do intervene before reaching this point. And this figure showed the incidence of acute dissection and even rupture, and it is more high when the aortic size is reached more than 6 centimeter. And here another figure, it shows that the rupture has a risk of 3.7 and dissection 3.9, and even unexplained death in 11.8% in patients with aortic aneurysm. So it is very important to identify the patient who are at risk and to intervene earlier before this catastrophic complication happened. Based on these observational studies, the latest guidelines released by the American Heart Association have put some recommendation for patients who should undergo the surgical intervention. In case if the patient is asymptomatic, we have the class 1 asymptomatic patient with degenerative thoracic aneurysm or chronic aortic dissection or even penetrating atherosclerotic ulcer. The aortic sinus diameter is 5.5 or greater should be evaluated for surgical repair. Patient with Marfan syndrome or other genetically mediated disorder like vascular Ehlers-Danlos or Turner syndrome, they should undergo elective operation at smaller diameter, which range from 4 to 5 centimeter depending on the condition. And this to avoid acute dissection or rupture, because they are more prone to have these complications. Patient with growth rate more than 0.5 centimeter a year is also an indication, class 1 indication, in aorta that is less than 5.5 centimeter in diameter. Patient undergoing aortic valve repair or replacement and who have an ascending aortic or root or aortic root of greater than 4.5 also should be considered for concomitant repair of the aortic root or replacement. The class 2A it said that elective aortic replacement is reasonable for patients with Marfan syndrome or other genetic diseases or even a bicuspid aortic valve when the ratio of maximal ascending aortic root area in centimeter divided by the patient height in meter exceed more than 10. And this is very helpful, especially in patients with short stature or even a young patient. The other recommendation said it is reasonable for patients with Loeys-Deitz syndrome or a confirmed transgrowth formation BR1 or B2 mutation to undergo aortic repair when the aortic diameter reaches 4.2 centimeter or greater. If it is diagnosed by transesophageal echocardiogram, which show the internal diameter or if it is diagnosed by CT or MRI, if it is reached to 4.4 or even 4.6. Presence of symptoms is class 1 indication, and this patient should go elective surgery for replacement of the ascending aorta. For aortic arch aneurysm, it is class 2A. For thoracic aortic aneurysm, which also involving the proximal aortic arch, so a partial arch replacement together with the ascending aorta repair, either using right subclavian or axillary artery inflow and hypothermic circulation arrest is reasonable. Replacement of the entire aortic arch is also reasonable for acute dissection when the arch is aneurysmal or there is extensive aortic arch destruction and leakage. Replacement of the entire aortic arch is reasonable for aneurysm of the entire arch, or a patient develop chronic dissection when the arch is enlarged, and for distal arch aneurysm. For patient with low operative risk in whom an isolated degenerative or atherosclerotic aneurysm of the aortic arch is present, operative treatment is reasonable for asymptomatic patients when the diameter of the arch exceeds 5.5 centimeter. A patient with isolated aortic arch aneurysm less than 4 centimeter in diameter, it is reasonable to re-imaging using CT or MRI at a 12 months interval to detect enlargement of the aneurysm. If it is more than or greater than 4 centimeter, we have to re-image them at 6-month interval and to see the progression of the enlargement. Pregnancy, it is another challenging, especially in aortic dilatation. So class 1 revealed that women with Marfan syndrome and aortic dilatation, as well as patients without Marfan, who have known aortic disease, they should be consulted about the risk of aortic dissection, as well as the heritable nature of the disease prior to their planning for pregnancy. If they are pregnant and they have a non-thoracic aortic dilatation or familial or genetic predisposition for aortic dissection, we have to control the blood pressure and to prevent any increase in hypertension. For all pregnant women with non-aortic growth or ascending aortic dilatation, monthly or bi-monthly echo measurement of the ascending aorta are recommended to detect aortic expansion until birth. And these are class 1. For imaging pregnant women with aortic arch descending or abdominal aortic dilatation, MRI without gadolinium is recommended over the CT imaging to avoid exposing both the mother and the fetus to ionizing radiation. TEE is an option for imaging of the thoracic aorta. Pregnant women with aortic aneurysm should be delivered where cardiothoracic surgery is available. Fetal delivery via cesarean section is reasonable for patients with significant aortic enlargement, dissection, or severe aortic valve regurgitation, and this is class 2A. Class 2B, if progressive aortic dilatation or an advancing aortic valve regurg are documented, so we have to do prophylactic surgery, may be considered in these patients. Here is the summary for recommendation. So I'm gonna throw it quickly. The general population, if the aneurysm is more than 5.5 centimeter, or the growth rate is more than 0.5 centimeter a year. For Marfan syndrome, it is more than 5 centimeter in the ascending, a less family history of dissection, so lower threshold, less than 5, or growth more than 0.5 centimeter. More than 4 centimeter and contemplating pregnancy, it is class 2A for Marfan patients. Loeys-Deitz syndrome, if it is more than or equal 4.2 centimeter by transesophageal echocardiogram, internal diameter, or more than 4.4 to 4.6 by CT or MRI. Bicuspid aortic valve, as per 2014 American Cardiology, The guidelines said if it is more than 5.5 centimeters, class 1 for ascending replacement. If it is more than 5 centimeters with a risk factor for dissection, like a family history of aortic dissection, or even a growth rate of more than 0.5, it is a class 2A. If we plan for aortic valve repair or replacement, a lower threshold for the size, which is more than 4.5, is recommended. Medical therapy, it showed the benefit in some cases to slow the growth of the thoracic aortic aneurysm and to reduce the risk of dissection or rupture. And currently, it is recommended that all patients with Marfan be considered for beta-adrenergic blockage to reduce the anatropy and chronotropy, and thereby reducing both acute and chronic hemodynamic stress on the aortic root. In case the beta blocker intolerance trial with the calcium channel blocker is indicated, exercise restriction and hypertension should be monitored and controlled carefully. These are some studies that showed the benefit of beta blockers and angiotensin converting enzyme, reducing the growth rate and also slow the growth of the ascending aortic aneurysm. Based on this, the American Heart Association released a recommendation for each risk factor. For blood pressure control, is class A, antihypertensive therapy should be administered to hypertensive patients with thoracic aortic disease to achieve a goal of less than 140 by 90 millimeter mercury in patients without diabetes. If they have diabetes or even chronic renal disease, the hypertension should be lower than 130/80. Beta blocker should be administered to all patients with Marfan syndrome and aortic aneurysm to reduce the rate of aortic dilatation unless contraindicated. Class 2A for patients with thoracic aortic aneurysm, it is reasonable to reduce blood pressure with beta blocker and angiotensin converting enzyme inhibitor, or even ARBs to the lowest point patient can tolerate without adverse effects. Losartan, which is angiotensin receptor blocker, is reasonable for patients with Marfan syndrome, and it showed that it reduced the rate of the aortic dilatation unless this drug is contraindicated. For dyslipidemia, statin was recommended as a class 2A to lower the target cholesterol of less than 70 millimeter, and this in the case of degenerative or atherosclerotic aneurysm. Smoking cessation is a class 1 indication in all patients who has aortic aneurysm. And let's move to the surgical treatment. The optimal timing for surgical repair of thoracic aortic aneurysm is somewhat uncertain. It is elective, it is urgent, and because the diversity in the growth rate and also the ascending aortic aneurysm, we have to tailor the intervention according to the patient individual. The major objectives of surgical treatment are to alleviate symptoms related to the aortic disease and reduce the frequency of the complication associated. There are some options for the surgical, like Bentali, Yaqub, or David, and Rose procedure aortic. I'm going to talk about some of them later on this presentation. And the recommendation for open surgery for ascending aortic aneurysm, class 1, we have to do separate valve and ascending aortic replacement are recommended in patients without significant aortic root dilatation, or an elderly patient, or even a young patient with minimal dilatation who have aortic valve disease. Patients with Marfan or other genetic mutation and other patients with dilatation of the aortic root and sinuses of Valsalva should undergo excision of the sinuses in combination with modified David reimplantation operation if it is technically feasible and the surgeon is experienced. If not, so root replacement with valve graft conduit is recommended. choice of operation, we have many factors that we have to put in mind before we push the patient for surgery, like age and expected survival, the underlying pathology and quality of the aortic wall, the anatomic condition of the annulus, the valve leaflet, the sinuses, even the condition of the distal aorta, it is involved or not, the risk of anticoagulation, especially in female patient, or even a presence of active annular infection. The age, like in older high-risk patient, separate valve and ascending aortic replacement may be the appropriate therapy. But if the life expectancy is limited, so a reduction aortoplasty is less technically demanding with less complication than the tube graft replacement. But the long-term results reveal a significant risk of the recurrent dilatation. The underlying, like a weakened aortic wall in patients with Marfan or dissection will require complete excision of the dilated portion of the aorta and the root as well. And the Benta procedure has proved the most versatile and durable reconstruction in such patients. The anatomic condition of the annulus and the valve, its important element usually dictates whether the valve can be spared or whether a separate valve ascending aortic replacement may be feasible. Usually, the ideal candidate for valve sparing root replacement is the patient with normal valve and annulus in whom dilated sinotubular bridge or dilated sinuses leads to aortic insufficiency. Risk of anticoagulation, especially in a young female who desire for childbearing, it is recommended that valve sparing root repair or perhaps a pulmonary autograft may allow long-term durability, but it is depend on the patient and the risk and benefit. Perioperative preparation for such cases, we have to do pulmonary function, ABG, smoking cessation, a normal renal function should be ensured. Severe carotid disease is a risk factor for stroke during ascending aortic operation, and so every patient who is more than 65 of age should have a duplex imaging of their carotid. CT or MRI of the thoracic and abdominal aorta is usually indicated. Angiography should be performed in all patients prior to the surgery. In monitoring in the OR, the arterial line for blood pressure monitoring, which is generally right radial, is preferred. Nasopharyngeal and bladder temperature monitor are used, especially in deep hypothermic security arrest. Bilateral near infrared spectroscopy is employed to estimate cerebral saturation. EEG monitoring is also employed to ensure EEG silence during the interruption of cerebral circulation, and TEE is mandatory in these cases. Myocardial protection, typically 1 liter of cold blood hyperkalemic cardioplegia is given antegrade into the aortic root. But in case of severe aortic insufficiency, the aorta is opened at the coronary ostia are cannulated directly with handheld. LV vent is employed to prevent LV distension. Temperature probe is placed through the anterior myocardium to achieve the goal of 6 to 8 Celsius degree. And retrograde cardioplegia is administered at least every 20 minutes and continuously when possible. Circulation management, the cannulation strategies vary significantly with individual pathology, either axillary or femoral. An aneurysm which terminates prior to the innominate artery, the transverse arch is easily directly cannulated. In cases where antegrade cerebral perfusion is required, either the ascending aorta or may be cannulated directly if using selective direct perfusion cannula, or the right axillary artery may be employed in such cases. Venous cannulation is achieved by single two-stage cannula in the atrium or bicaval cannulation strategy if we use the retrograde cerebral perfusion. Antegrade and retrograde cerebral perfusion techniques the antegrade primary beneficial over the retrograde in situation where the expected circulatory arrest time is greater than 35 to 45 minutes. So direct cannulation of the cerebral vessels with the balloon tip catheter or by the right axillary cannulation when the anominant artery is either snared or clamped at its origin, while antegrade cerebral perfusion via this method is rapid and effective, and it only provides unilateral perfusion and contralateral ischemia may still occur. The retrograde cerebral perfusion via the venous circulation, usually the superior vena cava, it provides cooling and excellent de-airing of the cerebral circulation. So we used 24 French wire reinforced cannula placed ceval to the zygous vein in the superior vena cava and secured with the cable tape. This is a proposed algorithm approach for decision making for proximal aortic aneurysm. So if you have suspicion of connective tissue disease or disorder, proximal reconstruction may be accomplished by either root replacement or a valve sparing root reimplantation procedure. The second thing is to determine the pathology of the aortic valve, like in case of moderate or worse aortic stenosis with or without insufficiency, generally require replacement. In cases of pure aortic insufficiency, we have either aortic insufficiency caused by dilatation of the sinotubular junction, and this typically from an atherosclerotic aneurysm in elderly patient may be full addressed with a tube graft replacement and keep the valve intact. If there are aneurysmal sinuses and annular dilatation, that is aortoannular ectasia, but the leaflet appears fairly normal, then a valve-sparing aortic valve reimplantation is often visible. If the annulus or sinuses are dilated and the leaflets are abnormal and not repairable, root replacement is performed. So I will start by the first surgical techniques, which is replacement of the ascending aorta with prosthetic graft. So the arterial perfusion cannula is placed in the proximal aortic arch, and then cardiopulmonary bypass is initiated, the aorta is occluded, and cardiac arrest achieved with the cold cardioplegia given retrograde through the coronary sinus, and then we have to open the aorta 1 centimeter above the sinotubular junction till the aortic cross clamp. The entire aneurysmal portion is removed, taking care to avoid injury to the right pulmonary artery, which lies directly behind the ascending aorta. Then a prosthetic graft is tailored and attached to the distal aorta in end-to-end fashion. And with the stitches line is first constructed in the back wall of the aorta and carried up in the front of the anastomosis. After that, the prosthetic graft is trimmed appropriately to avoid excessive length, which can result in kinking of the graft. And then the graft is attached to the sinotubular junction of the native aortic root using a continuous stitches of 4O Prolene. At the end of the surgery, we used T-seal or BioGlow to reinforce the suture line before removing the aortic cross clamp, and this will help in the sealing of the needle hole, and more significant area of bleeding should be reinforced with interrupted Blodgett suture. If the aneurysm involves the distal ascending aorta or the proximal aortic arch, the hemi-arch technique should be used to resect all the aneurysmal tissue. The arterial perfusion in this case should be placed in the distal aortic arch. The cross clamp is placed at the confident point of the dilated ascending aorta and the aorta is transected 1 centimeter above the STG and below the cross clamp. Then we have to apply a short period of circulatory arrest under deep hypothermia to construct the distal aortic anastomosis. The cross clamp is removed and the aorta is trimmed to the level of the innominate artery and beveled underneath the aortic arch. Prostatic graft, Dacron graft, is selected and beveled to match the hemi-arch configuration. It is attached in end-to-end fashion using continuous stitches. The suture line is first constructed across the back wall of the aorta and carried up to in front of the anastomosis. Then we have to do cardiopulmonary bypass reinstitution and the airing maneuver to evacuate air and debris from the arch vessels and the descending thoracic aorta. After appropriate the airing, the cross clamp is placed on the distal portion of the prostatic graft and full cardiopulmonary bypass is reestablished. The prostatic graft is trimmed appropriately and attached to the sinotubular junction of the native aortic root, and then reinforced with a bioglue or surgical glue to reinforce the suture line before removing the aortic cross clamp. The second techniques, which is replacement of the ascending aorta and the aortic root. Concomitant replacement of the ascending aorta and the aortic root is necessary when there is combined disease involve the ascending at the root as well. Aortic dissection that extends deep into the aortic root, rendering the aortic valve irreparable, is an indication for replacement of both the ascending aorta and the aortic root. Another common indication for replacement of ascending aorta and the aortic root is aortic valve incompetency due to root dilatation from aneurysmal disease, such as that associated with Marfan syndrome. Additional indication is a bicuspid aortic valve with associated dilatation of the ascending aorta. Durable repair is achieved with the use of either composite mechanical valve conduit or a tissue aortic root, bioprosthesis, and prostatic graft. So in this case, the arterial perfusion cannula is placed in the distal ascending aorta or proximal aortic arch, depending on the extent of the ascending aortic aneurysm. The cross clamp is placed in at the distal aorta, and retrograde cardioplegia is used to arrest the heart. The aorta is transected 1 centimeter above the sinotubular junction and 1 centimeter from the aortic cross clamp, and the aneurysmal aorta is resected. After that, the aortic valve is excised and the aortic root is exposed and enhanced by placing traction stitches at the top of each commissure. The aortic tissue is removed from each sinus, leaving a 5 to 6 millimeter of the aortic annulus, and the left and right coronary artery are mobilized on the generous bottoms of the aortic sinus tissue. The diameter of the aortic annulus is measured, and the mechanical valve composite graft is selected for the repair, or a porcine aortic root prosthesis can also be used. Interrupted mattress stitches of 2O braided suture are placed down through the aortic annulus and brought up through the swing ring of the prosthesis. Suture placement is started in the right coronary sinus and proceed in a clockwise fashion, similar to standard aortic valve replacement. The valved composite prosthesis is lowered down on the aortic annulus, ensuring that the valve is seated properly without impinging on the leaflet or the valve occlusion mechanism. The suture are tied down first in the non-coronary sinus and then in counterclockwise fashion. After that, we have to make an opening in the diaphragm graft exactly opposite in the coronary artery ostia using a battery-operated cautery. And the large openings makes the technical aspect of the repair easier and avoid narrowing of the anastomosis of the coronary ostia. Adequate amount of the graft should be left between the bottom of these openings and the swing ring of the prosthesis. The left coronary ostium is attached first using a continuous stitches of 5-polypropylene, and all the suture lobes are placed around the inferior rim of the coronary ostia before they are tightened in order to accurately approximate the ostium to the graft opening. Both coronary ostia are approximated to the graft in similar fashion. The right coronary artery anastomosis can be completed either before or after the distal aortic anastomosis if there is concern about the proper orientation of the right coronary artery. Secure and accurate stitches must be placed in the coronary artery bottom wall for secure approximation to the side of the graft. Use of BiGlow is advised to support this critical coronary reimplantation. The distal end of the graft is trimmed to an appropriate length and attached in an end-to-end fashion using a continuous stitches. The suture line first constructed in the back wall and then brought up in the front of the graft. We may use the short collar graft material to support the distal anastomosis of the aorta, and the collar must be cut and placed around the graft prior to construction of the anastomosis. We can also use the BioGlue to insert beneath the collar and to reinforce the suture line and to prevent any oozing from the stitches. There are some tips and tricks regarding the coronary reimplantation. When there has been extensive dissection into the coronary arteries, the main coronary arteries must be trimmed back to some degree, and we use a small and short interposition PTF graft can be used to compensate the loss of the coronary artery length. The interposition graft are attached in end-to-end fashion to each main coronary artery. And careful attention must be paid to the length of each interposition graft to avoid any kinking and improper orientation of the coronary. An alternative method is to use a single interposition graft for reimplantation. So the left main coronary artery is trimmed back to a healthy tissue, and the small prosthetic graft is attached to end-to-end fashion, and this prosthetic graft is then routed behind the main composite graft and attached to the front of it. The right coronary artery is also trimmed back to healthy tissue, and the small opening is made on the side of the prosthetic graft, and the right coronary artery is attached. In cases of Marfan type aortic aneurysm, the coronary ostia may be widely separated by the sides of the aneurysm. So an interposition graft may be anastomosed directly to the aorta around the coronary ostia without resection of a part of the aortic aneurysm, of the root aneurysm. The interposition graft may be anastomosed to posterior aspect of the aortic graft or anteriorly as seems best for a patient. Valve sparing aortic root, it is a very demanding procedure, but it still give a long-term durability in young patient. So we have Yaqub procedure and David procedure. Yaqub procedure, as illustrated here, cardiopulmonary bypass is established as usual. The aorta is occluded and retrograde cold cardioplegia given through the coronary sinus. The aneurysm of the ascending aorta is incised longitudinally, and the aorta is divided distally above the aneurysm. After that, the aortic valve is inspected to determine the feasibility of the repair. If the aneurysmal disease is restricted to the aorta with dilatation of the sinuses of Valsalva, it may be possible to preserve the aortic valve. So the aortic valve cusp should be normal in Yacoub procedure. There should be no dilatation of the aortic annulus, although there are techniques to narrow the annulus, but in this situation, despite deplicated hair, the aortic valve is determined to be incompetent due to separation of the commissures by aneurysmal dilatation of the aorta. So the sinuses aorta is excised, retaining only a 3 to 5 millimeter rim above the annulus, and a button of sinus of aorta is retained around the ostia of the left and right coronary arteries. After that, we have to obtain the dimension of the aortic leaflet, and the length of the free margin of the leaflet also determined, and the height of the leaflet should be measured. The sinotubular diameter is calculated using the dimensions by the Konzelman, which state that if the diameter of the aortic root at the annulus is taken as 1, so the diameter of the sinotubular junction, which also be the diameter of the prostatic graft, should be 0.9 of the annulus diameter. So, for example, if the diameter of the aortic valve annulus measured about 25 millimeter, a 22 millimeter tubular prosthesis is chosen as per the equation. A practical method for selecting appropriate size prosthetic graft is to simply measure the annulus, as would be done for aortic valve replacement, and choose a tubular graft diameter that is about 90% of the diameter of the annulus. And then the graft of the appropriate size is selected. Dacron graft is usually used. The graft is cut at the 3 symmetrical point to accommodate the commissures of the aortic valve. The cuts usually extend 6 or 7 crimp bridges into the graft, depending on the height of the leaflet. And the graft material between these cuts will become the reconstructed sinuses of Valsalva. So the edges of the graft are attached to the sinus aorta remnant at the hinge point of the aortic leaflet. Continuous stitches of 3 or 4 polypropylene are used for the repair. The commissures of the aortic valve are brought into the apices of the cuts in the graft. After that, we have to make opening into the graft opposite the location of the coronary arteries using a hot cautery. The coronary arteries are anastomosed with 5-O polypropylene. Then the end-to-end anastomosis of the graft to the aorta completes the repair, and all vascular anastomoses are sealed with bioglue or T-cell. This is in regard to Yacoub procedure. David procedure is another technique for valve sparing. So the aortic root is dissected well below the aortic annulus, as shown here. It is particularly important to carry the dissection below the root and behind each commissure, because the graft will be seated outside of the root and below the annulus. The aortic sinus tissue is excised, retaining a 3 to 5 millimeter of the annulus, and the buttons of the sinus tissue are retained around each coronary ostia. And we may use a suture at the commissure, each commissure, taking care not embedding any leaflet tissue. 2O braided blister sutures are placed in a mattress fashion below the aortic annulus and passed to the outside of the aortic root. 3 stitches are placed in each sinus, with 1 suture at the lowest point of the valve and one suture slightly higher on each side toward the commissures. And this suture should be narrow to avoid crimping and distorting the annulus. After that, the diameter of the annulus is measured and the graft 3 to 4 millimeter larger than the annulus is selected and trimmed, leaving 2 to 3 rings below the proximal reinforced collar. Each of the subannular stitches is brought through the lower portion of the graft. And again, this suture should be narrow to avoid crimping and distorting of the graft. The graft is lowered into the root by gentle pulling. And the braided suture are also gently tightened to ensure that the graft is seated well down to the root and below the annulus. So after that, the braided suture are tied to secure the graft to the left ventricular outflow tract, and the suture should be tied gently to avoid graft distortion. Then the 3 sutures are passed through the graft at the level of the distal reinforced collar. The guidelines on the graft assist in proper location of the stitches. And to prevent aortic insufficiency, it is critical to ensure that the commissures are all at the same height. And placing these sutures at the distal reinforced collar maintain the proper elevation and diameter of the valve. After that, 3 continuous 4/0 polypropylene sutures are used to attach the retained rim of the aortic sinus tissue to the graft. And the sutures are begun at the lowest point of the sinus and brought up to the top of each commissure. 4/0 and 5/0 polypropylene sutures are tied outside the graft to secure the top of the commissures, and the valve is tested for competency. The coronary buttons are reimplanted into the openings made in the graft and in the left and right sinuses of the graft. Then the distal end of the graft is trimmed to appropriate size and attached to an end-to-end fashion to the aorta. And then we can use the BioGlue for reinforcement of all suture lines. This was in regard for ascending aortic aneurysm. For the aortic arch replacement, there are many techniques that have been described. I will go through some of these techniques. So there has been a diversity of surgical approach. Originally reported in 1960s, the first arch aneurysm repair was completed using an island technique. In 2000, Caso et al. Developed an integrated D-branch arch graft that contained 3 fixed limbs of anastomosing the great vessels and a side arterial cannulation limb for cardiopulmonary bypass. In 2002, Spielophysiol et al. Described the technique of debranching the great vessels from the arch and anastomosing them to a trifurcated graft that could be sewn to the main aortic graft. And all of these techniques improve the patient outcome by decreasing the duration of the DHCA and improving the cerebral protection and excluding the disease aorta from the anastomosis. So start by the island techniques. So axillary cannulation with the prosthetic side graft is used to facilitate both full perfusion and low flow antegrade cerebral perfusion during hypothermic circulatory arrest. The arterial return cannula is inserted into the side graft, allowing the arch to be perfused without compromising the flow to the right arm. So hypothermic circulatory arrest is initiated and the arch is resected in island fashion, along with the superior aspect of the arch is created. The proximal descending thoracic aorta is trimmed and the aortic root remains intact. An appropriate size prosthetic graft is selected and attached an end-to-end fashion to the descending thoracic aorta. And particular care is taken to ensure a secure anastomosis in this area because this portion of this repair is difficult to assess after the operation is completed. After that, an oval-shaped portion is removed along the superior aspect of the prosthetic graft to match the arch vessel island. The island is attached to the prosthetic graft, and de-airing maneuver are used as cardiopulmonary bypass is reinstituted. The graft is occluded proximal to the arch vessel island anastomosis. The proximal end of the graft is trimmed to an appropriate length and attached to an end-to-end fashion to the ascending aorta. And care is taken to bevel the graft and avoid excessive length, which can result in kinking of the graft. To complete the operation, we have to use the bioglue or TCL to reinforce all suture lines. The other techniques is prefabricated triple branched graft with side perfusion branch. The graft has 3 segments along the exterior curve for implantation of the arch vessels, as well as 4th segment on the opposite side for perfusion cannula. Auxiliary cannulation is used to facilitate low flow antegrade cerebral perfusion during hypothermic circulatory arrest. Use of prosthetic side graft allows uncompromised flow to both the arch and the right arm. Short period of circulatory arrest under deep hypothermia is employed to open the aortic arch and transect the aorta above the aortic root and beyond the arch. The arch vessels are transected near their origins from the aortic arch, and each vessel should be trimmed back to a relatively healthy tissue in case of extending aneurysm. So the ascending aorta and the arch are removed, leaving a ghost shape. The innominate artery is occluded, and the low flow integrate perfusion is initiated through the axillary cannula at low flow to provide additional cerebral protection and to evacuate air and debris from arch vessels. The arch vessels are occluded and prepared for the anastomosis. The prosthetic graft is attached to an end-to-end fashion to the proximal descending thoracic aorta. Then a left subclavian artery is attached to the most distal of the 3 segments on the exterior curve of the graft. After complete anastomosis of the left subclavian, a perfusion cannula is placed in the side graft located on the inferior curve of the main graft. A clamp is placed across the main graft just proximal to the left subclavian, directing flow through the side graft into the left subclavian artery and down to the descending thoracic aorta. The left common carotid artery is attached to the middle segment on the superior curve of the graft. The clamp on the main graft is moved proximal to the allow perfusion of both the left subclavian and the left common carotid artery, and the innominate artery is attached to the most proximal of the 3 segments. So the clamp should be moved proximally again to the main graft to allow perfusion to all the arch vessels and the descending thoracic aorta, and the main graft is trimmed on appropriate length and attached in end-to-end fashion to the ascending aorta using continuous stitches of 4O polypropylene. Upon completion of this procedure, bioglue is used to reinforce all suture lines. Cardiopulmonary bypass is discontinued, and the side branch perfusion graft is trimmed nearly flush with the main graft and then overswung and imbricated to provide a smooth surface, which will be in direct contact with the pulmonary artery in front of it. And the side graft of the right axillary artery is also trimmed and overswung. Elephant trunk procedure is part of a two-staged approach to treat arch aneurysm with extensive pathology distal to the left subclavian artery. The perfusion is accomplished by a single venous uptake cannula. Oxygenated blood is returned to the femoral artery, and the patient is perfused with blood cooled to 12 Celsius degree until the body temperature, the nasopharyngeal, reach 16 to 80. Dissection of the aortic arch is minimal, so no occluding clamp are used. The aortic aneurysm is open throughout its length, extending through the aortic arch, but not dividing the vagus nerve, which lies on the surface of the distal aortic arch. The aortic arch vessels are left open and dissection extending through the aortic arch as illustrated in this figure. All the loose intima and media are excised from the ascending aorta and arch, and the excision is extended into the descending thoracic aorta as far as possible through the arch aortotomy. The arch repair is accomplished by an elephant trunk techniques for a later reconstruction of the descending aorta by direct graft anastomosis. An appropriately sized collagen cell, the dacron graft, is selected. The graft is invaginated, leaving a folded back portion approximately 5 centimeters long. And the bolstering of 2O silk is attached to the proximal end of the invaginated end of the graft and brought back through the lumen of the graft. The graft is pushed down into the descending aorta. The folded edge of the graft is anastomosed to the aorta beyond the left subclavian artery. Then we have to pull the string used to retrieve the graft from the distal aorta. The graft is pulled back into the arch, leaving a 5 centimeter of graft extending and attached beyond the anastomosis in the descending thoracic. The branches of the aortic arch are anastomosed to the graft as a unit. After the arch vessels are anastomosed to the graft, circulation can be restored to the head vessels and the rest of the body by retrograde perfusion through the femoral artery at low flow. The head is lowered and the blood is allowed to flow slowly into the carotid arteries to fill them without tampering air. The head vessels are probed gently with the hemostat to dislodge air and debris through the graft and out of the open proximal end. The graft is occluded proximally to the arch vessels, and full flow perfusion is established with rewarming of the body, and the ascending aorta is reconstructed by anastomosing of the proximal end to the graft. Techniques I will speak about the arch first techniques. In cases of marked aneurysm enlargement, that is when the diameter of the thoracic aorta exceeds 4.5 centimeter, safe attachment of an elephant trunk graft just distal to the origin of the left subclavian artery may not be possible. It may be necessary to make anastomosis to the mid portion of the descending thoracic aorta, or even further distally. Some cases of chronic type A aortic dissection that require a second stage operation for replacement of the aortic arch, and after replacement of the ascending aorta may benefit from this approach because the upper portion of the descending thoracic aorta may be significantly enlarged, requiring aortic replacement to a more distal point in the thoracic aorta. Kochikos described these techniques and is credited with developing a safe method for treating such cases which are associated with significant risk of hemorrhage or even a cerebral ischemic injury. So a technique started by general anesthesia induced with the patient in the supine position. A double lumen endotracheal tube is used to allow collapse of the left lung. If arterial perfusion via the left common femoral artery is selected, the catheter is inserted with the patient in the supine position. And if the axillary artery is to be used, the arterial catheter is inserted after the thorax is entered and the patient is rotated 20 to 30 degrees to the right. The left arm is abducted and secured. A bilateral submammary incision is made in the fourth intercostal space. And the drawback of this procedure that both internal mammary arteries are ligated. We have to sacrifice the mammary artery in this procedure. And the sternum is divided transversely, as illustrated in this picture. The left lung is collapsed, the pericardium is opened minimally over the aorta, and the right atrium to allow placement of venous uptake cannula. Cardiopulmonary bypass is established, and we call the patient to 60 to 80 degrees. The left phrenic and left vagus nerve are mobilized on the pleural pedicle. The ascending aorta is clamped when ventricular fibrillation occurs or at any point when cardiac distension is observed. If the aortic valve is competent, we have given cold blood cardioplegia administered into the aortic root. But if the aortic valve is not competent, the aorta is opened and cold cardioplegic solution is given retrograde through the coronary sinus. The aorta is divided proximal to the closing clamp, as illustrated in this picture. When the target body temperature is reached, cardiopulmonary bypass is discontinued and the patient head is surrounded with ice packs and the head is lowered. The tourniquet around the superior vena cava is tied. A clamp is placed on the descending thoracic aorta below. The proposed site for distal aortic graft anastomosis. The aortic arch branch arteries are removed from the arch as an island surrounded by a small aortic arch cuff. The aorta is divided distally to the origin of the left subclavian artery. The descending thoracic aorta is incised longitudinally, beginning distal to the neural pedicle and extending to a point where the aorta approach near normal. Then a tubular collagen sealed polyester is selected. The graft diameter should match. The distal end of the graft is pulled beneath the neural pedicle into the descending thoracic aorta. The vascular arch island is anastomosed to the prostatic graft. The anastomosis is sealed with bioblow, and the descending thoracic aorta is divided in a baffled fashion. Cold oxygenated blood is infused into the cannula in the superior vena cava to raise the venous in the upper compartment, which sufficiently to force blood to flow retrograde from the brachiocephalic artery into the arch graft and helping removing the air and debris from arch vessels. A vascular clamp is placed on the arch graft just distal to the arch initiated.
Ahmed?
Sorry, I don't know what happened. You see my slide right now?
Yes, we can see it.
All right, so to retrograde perfusion of the superior vena cava is discontinued. The aortic graft is occluded proximal to the arch anastomosis, and antegrade perfusion of the arch vessels with cold blood is initiated. The occluding clamp is removed from the descending aorta, and the aorta is beveled appropriately to preserve the intercostal arteries below the sixth intercostal space, and the graft is divided and beveled to match the aorta. End-to-end anastomosis of the graft to the aorta is constricted, and the anastomosis may be reinforced with Teflon felt strip or beveled Dacron collar. After we did anastomosis to the descending thoracic, before final completion of the distal aortic anastomosis, the distal aorta is temporally occluded to allow a dry field as the anastomosis is sealed with BioGlue. The graft is punctured a few times with an 18-gauge needle to allow air to evacuate as the clamp is removed from the aortic graft proximally. The perfusion flow rate is restored and rewarming of the body is commenced. Patent intercostal arteries and bronchial arteries in the upper descending aorta are closed by sutural ligation. The proximal end of the graft is shortened and anastomosed to the ascending aorta in the aortic root replacement. A Teflon felt strip or beveled Dacron collar reinforces the anastomosis, and the aortic anastomosis is sealed with a BioGlue. A needle vent is placed in the graft to evacuate any air in the graft. The last remaining clamp is removed from the aortic graft to allow coronary artery reperfusion. And when the heart is beating vigorously and the body temperature has been restored to a normal, cardiopulmonary bypass is discontinued and cannula are removed and the stab sites are closed and the side graft is removed and overswing. I'm concluded here. I know it is a little bit, but just for home messages, the ascending aortic aneurysm is a lethal disease. Elective surgical repair remains the mainstay for the management of symptomatic patients. Indication for surgery are based mainly on the aortic diameter. The surgery should be performed in patients with Marfan syndrome who have maximal aortic diameter more than 50 millimeter. A lower threshold of 45 millimeter can be considered in patients with additional risk factor, including family history of dissection, severe aortic regurg, or desire for pregnancy. Patients with Marfanoid manifestation due to connective tissue disease without complete Marfan criteria should be treated as a Marfan patient. Earlier intervention have been proposed for aortic diameter of more than 42 millimeter in patients with Loeys-Deitz. Surgery should be performed in a patient with bicuspid aortic valve who have a maximal aortic diameter of more than or equal to 55 millimeter. The choice between a total replacement of the ascending aorta, including the aortic root, by coronary implantation and a segmental replacement of the aorta above the sinotubular junction depends on the diameters at different sites of the aorta, in particular the sinuses of valve size. In cases of total replacement, the choice between the valve sparing intervention and composite graft with the valve prosthesis depends on the analysis of the aortic valve function and the anatomy, the size and size of the aneurysm, the life expectancy of the patient, desired anticoagulation status, and the most important, the experience of the surgical team. Surgery should be considered in patients who have an aortic arch aneurysm with a maximal diameter of more than or equal to 55 millimeter, or who present symptoms or signs of local compromise. Thank you very much, and I'm sorry for this long lecture.
يعطيك
Any
العافية
question?
دكتور.
الله يعافيك.
يعطيك العافية.
Thank you, Ahmed, for this thorough lecture. Anyone has a question or comment for Ahmed? Okay, thank you everyone for joining us today, and see you next week, inshallah.